All right, thanks everybody. Thanks for inviting me here. I am not a formally trained implementation scientist. I am an STD and HIV doctor who is interested in sort of programmatic things, and so, hello Janet, and so has kind of backed into implementation science to further my goals. So with that, I'm going to talk about one of the pillar programs of the San Francisco Getting to Zero initiative, which is our rapid ART program initiative for new HIV diagnoses. So, as most of you probably know at this point, on the basis of a number of internationally conducted randomized trials of immediate ART versus standard of care, the WHO in 2017 endorsed immediate antiretroviral therapy on diagnosis, which was operationalized as within 7 days of diagnosis for all newly diagnosed persons if they were willing to start. There's been some divergence of opinion towards immediate ART in the United States. The DHHS treatment guide, so the two main guideline committees now diverge on their recommendations. The DHHS still regards immediate antiretroviral therapy as an investigational approach, with their primary concerns being the increased resource demand of starting people quickly after diagnosis. Whereas in their most recent iteration of the guidelines, the international IAS USA has now endorsed immediate ART, although their definition is within 14 days of diagnosis. So against this background, and I should also say that both of those guidelines committees point to the lack of randomized controlled trials of immediate versus standard of care in the US as fueling some of their caution. So in the context of these recommendations. In 2015, the San Francisco Getting to Zero Consortium decided to adopt RAPID, citywide RAPID, so accelerated ART initiation for all newly diagnosed persons with HIV in San Francisco. And this was following on a successful pilot program conducted at Ward 86, the HIV clinic at San Francisco General Hospital. So the purpose of this analysis was to describe the RAPID program and examine our RAPID outcomes stratified by a number of sociodemographic variables, and also RAPID uptake by various different kinds of HIV providers across the city. So what did we do? We came up with a citywide RAPID protocol that stated that all new confirmed HIV diagnoses would be linked to care within 5 working days of their diagnosis, and that at their first care visit, they would undergo all of the usual baseline assessments that typically occur serially in newly diagnosed patients, and they would undergo them in parallel, and that first day they would be offered antiretroviral therapy. We came up with a consensus, a number of consensus regimens for rapid ART, because remember, these patients were going to be starting therapy without the benefit of any laboratory studies. So we wouldn't know their CD4 count, we wouldn't know their viral load, we wouldn't know if their virus harbored any transmitted drug resistance, and we wouldn't know their kidney function or liver function. So the consensus regimen was tenofovir plus FTC plus either an integrase inhibitor or ritonavir boosted darunavir, and there was an option for 4-drug therapy in people who were suspected to have acquired their HIV around the time of taking PrEP. So we disseminated this protocol a number of ways. We disseminated it to HIV clinics through peer-to-peer conversations, through grand rounds, and then in 2016 we started a detailing program for individual providers. And we identified priority clinics based on surveillance data from the Department of Public Health. We targeted clinics that had high volumes of who saw newly diagnosed patients in high volumes, and we also prioritized clinics who saw traditionally vulnerable populations, so racial ethnic minorities and youth in particular. And we were lucky in this regard because the founding clinic for RAPID in San Francisco was the SFGH Ward 86 clinic, which already saw a large proportion of those vulnerable populations. We also trained linkage navigators across the city in the basic tenets of RAPID, and we equipped them with a RAPID provider directory that was this ever-growing list of HIV providers who agreed to start antiretroviral therapy the same day of the first clinic visit and had mechanisms in place to do expedited intake of patients. And we included in that document the various kinds of insurance that these clinics accepted and any special features that they offered, such as special attention to youth. And we also disseminated these materials electronically through the Getting to Zero website and at open quarterly meetings. So we had some pre-specified outcomes. So we were, again, using routinely collected surveillance data from the surveillance branch at the SFDPH. And so we were interested in looking at time measured in median days from diagnosis to virologic suppression, defined as below 200 copies. And we were, within that, we were looking at various stages of the ART initiation continuum. So the time from diagnosis to first care visit to ART initiation to virologic suppression. And we used a number of statistical methods to look for differences in these median times across the 4 years that we were studying. And we were basically looking at ART initiation in the pre-rapid era, 2013, 2014, and then into the early rapid era, 2015, 2016. We were also interested we couldn't assign people to rapid or not, so we had to come up with a working definition of who got rapid started and who didn't. So we established what we thought was a pretty stringent definition. So we looked for people who were linked within 5 days and started ART within 1 day of that first clinic visit. And we interpolated that, or we abstracted that from surveillance data as well. And we were also interested in which providers across San Francisco were starting rapid on their patients. Okay. So a little word about HIV surveillance in San Francisco. San Francisco is incredibly fortunate to be one of the major metropolitan areas in the United States that gets its own CDC funding to do its own HIV surveillance. So many of you probably know this, but the way HIV surveillance is done across the country is at the state health department level, and then individual jurisdictions apply for information or get their information filtered. They send their information to the state and they get data back, and they have very little control and creativity over how the numbers are crunched, how things are lumped and split. San Francisco, we're lucky. We have a really, really innovative and dynamic HIV surveillance branch within the DPH, and we can ask for things. We can't ask for extra data collection, but we can ask for creative interpretation. So new HIV cases in San Francisco are identified through active and passive surveillance. So the surveillance branch goes out and looks for new infections through lab data, and they also get case report forms because, as you know, HIV is a reportable condition, and in San Francisco it's reportable to the city as well as the state. So at the initial case report, HIV serology, RNA, CD4, sociodemographics, date of ART initiation, date of diagnosis, and sites of diagnosis and care are all recorded through a combination of routine lab data and also chart review. And then there's systematic chart review every 6 to 18 months. It's more frequent early on to complete the data more quickly on recently diagnosed persons, and then the interval between visits lengthens. Again, many of those same indicators are collected longitudinally. The completeness of the data collected by the surveillance branch is very, very high. It's over 95%, and that's checked regularly in the annual HIV epidemiology report. So these are very complete data sets. The data, some things are not systematically collected, so we don't get systematic data on mental illness or substance use, and those are important caveats. And of course, all data were de-identified for these analyses. So what did we find? So very quickly, between 2013 and 2016, the number of new HIV diagnoses in San Francisco dropped quite dramatically from 399 to 265. It's still predominantly a male epidemic, although the proportion of new cases made up by females is increasing from 7% to 11%. In youth, it's increasing from 33 to 36. Sort of ethnically, the proportion of cases made up by Latinos is increasing a bit, and by Asian Pacific Islanders increasing a bit, and the proportion made up of people who are technically homeless has increased from 8% to 11%. So, we looked at linkage to care and ART initiation following HIV diagnosis, and you can see that in San Francisco, the vast majority of people who are diagnosed are in care, and that did not change much over 4 years, and the vast majority of them start antiretroviral therapy, around 80%. One thing that's interesting to note is that the proportion of people who started their ART with an integrase inhibitor increased from 47% in 2013 to 74% in 2016, and I think that you'll see that has a very important bearing on the speed with which people achieve virologic suppression, because integrase inhibitors drop the viral load faster than any other class of antiretroviral. So looking at the bottom line here, we also were gratified to see that the proportion of people who met our strict definition of a rapid start increased from 6% in 2013 to 30% in 2016. Okay, so this is the most important result slide, I think, and the bottom line really is the bottom line here. So time from diagnosis to virologic suppression dropped from 134 days in 2013 to 61 days in 2016, and that's a 54% drop. The linkage time, so time from diagnosis to care, which is already quite good, and really hats off to the LINCS team citywide and the FAST team at San Francisco General Hospital, was already good at 8 days in 2013, and it dropped 38% to 5 days in 2016. And the number that really shocked us in a good way was that the time from first care visit to ART initiation dropped from 27 days in 2013 to 1 day in 2016. Okay. And as you'll see, the time from ART to initiation to virologic suppression dropped from 70 days to 38 days. I think that's probably largely explained by the explosion in use of integrase inhibitors first line. Okay, I should also say that these, we've done some analyses of these by socio-demographic groups, and I'll show you some of those data at the very end of the presentation, actually in this slide right here. So we were especially interested in the overall time from diagnosis of virologic suppression and the time from first care visit to ART initiation. Okay, and so you can see that really across all socio-demographic groups we studied, age, sex, race, ethnicity, and housing status. Over on the left, time from diagnosis to virologic suppression dropped significantly across all groups, although by different percentages. Among Asian Pacific Islanders, the time dropped particularly noticeably by 70%. Among the homeless, a little bit less dramatically by 53%. And among Asian Pacific Islanders, for example, by 2016, time to virologic suppression was 43 days. That was the fastest of any group, whereas time among the homeless was the highest of any group at 71 days. And many other groups settled out in the 50 to 60 day range. Looking at the right side, the right table, this is first care to ART initiation. We were able to see that in men, in youth, and in people 13 to 39, in men, in Latinos, in Asian Pacific Islanders, and in the housed, time from care to ART initiation dropped to 0 days in those groups. And we were actually quite surprised at that figure, particularly in some of the more vulnerable racial and ethnic groups, and we ascribed that primarily to if, there's a big caveat, if rapid actually is the reason that these things happened, we think that it was our ability to target, or to prioritize, I should say, clinics that saw populations that are traditionally left out of advances in the HIV care cascade. Okay, so looking at who across San Francisco is prescribing ART, so we divided sites into the private sector and the safety net sector. So the private sector is in blue and the safety net sector is in orange. And you can see that this is the percent of new patients who were started on ART within 5 days of their first clinic visit. This is a slightly different metric than our stringent rapid metric. You can see that there were improvements in both sectors across many different sites. I would like to point out specifically that by 2016, 78% of new diagnoses seen at the STD clinic were started on ART within 5 days. 69% in the safety net system, including San Francisco General Hospital and the health network clinics, and 71% at a very large vertically integrated HMO in San Francisco that will remain nameless. That's the Kaiser data. Okay, so much for that. Okay. So over on the right in that table is showing what proportion of ART starts were done by site. And you can see that in 2016, 39% were done in the safety net clinics and hospital, 8% in the STD clinic, and 8% in other public clinics. So a very large proportion of patients were started rapidly in the safety net system. And I think that really points to the importance of basically Medi-Cal expansion in allowing rapid ART initiation in populations who really need it. And I will tell you from personal experience that people who were eligible for Medi-Cal or had Medi-Cal were the easiest people in San Francisco to do a rapid start in. People who had fully functional private insurance, you could do it. It was a little trickier to find providers in the network and to navigate the specific details of their individual plans. The people who are left out or hardest to rapid are the people who make too much money for Medi-Cal, who aren't yet enrolled in commercial insurance, or who have very high deductible plans. So they're the donut hole that we really need help in navigating to rapid ART. Okay, so what worked and what didn't? So this very large multi-sector citywide initiative to optimize ART initiation did achieve a couple of its goals. So we cut the time to first virologic suppression by more than half. We really cut the time to ART initiation down dramatically. And we think there were significant improvements in traditionally vulnerable populations, although that didn't apply to everyone. The homeless are still, homeless and African Americans are still lagging behind some other groups in speed of virologic suppression and speed of ART initiation. And we were happy to see that rapid uptake increased across the city, although the gains were particularly notable in the public sector, which is actually where we concentrated most of our efforts. We were also pleased to see that the number of people who started in a rapid fashion increased dramatically across the 4 years of analysis. We are currently finishing up some sociodemographic analyses of the proportion of patients within each sociodemographic group who were started rapidly to see if there are any important issues to address there. I think it's important to show, to discuss what is not happening. So 16% of people diagnosed in San Francisco are still not started on ART, and we're looking into that as well. I would say that surveillance data may not be granular enough to get at the reasons for that. I think that's going to require, I think most people agree, that's going to require much more intensive qualitative analysis. And Kat Christopoulos walked into the room. She is doing that, and I think we look forward very much to results of those studies. So a couple of thoughts. So this is an implementation science data meeting, so I had to include my thoughts about surveillance data, and take these with a lot of salt because I'm not really an implementation scientist. I've now worked with surveillance data to answer some questions and design a program that meant a lot to me. So this is kind of guerrilla implementation science here. But there are some really great things about using surveillance data. It's there already. You don't have to go out and collect it yourself. If you have a good relationship with your surveillance branch, they can be really helpful and creative in creating variables and doing analyses. It's routinely collected. It's very stringently collected. The data completeness is good. The data cleanliness is good. We were able to use it, I think, to map the care pathway in San Francisco, how people get from a new diagnosis to virologic suppression, and specifically geographically and in a clinic sense, where they go and where we should prioritize our efforts. It helped us, I think, prioritize traditionally vulnerable populations, and I think if this sort of ecologically analyzed program is convincing enough, I think we were able to kind of influence who got rapidly started. It is ecological data. We cannot show, surveillance data cannot show you an association between a program and an outcome. And if anyone has ideas about really, really innovative ways to cut the data, to look at that, to make a more convincing case that the program actually influenced the outcomes, I'd love to hear about it. It collects a limited number of variables. We didn't address mental illness, we didn't address substance use, but it collects those data very, very rigorously, completely, and systematically, and I think that's a huge strength. So that's it. So lots of acknowledgments. So to the Getting to Zero Consortium and the RAPID Committee, and Hiroyu and Chris and Diane, who really kicked off this whole idea. To the Links team at DPH and City Clinic, to the FAST and RAPID teams at SFGH, and to ARCHES, which is the home of the surveillance branch at SFTPH, and the Center for Learning Innovation, which created a lot of our detailing materials. So thanks very much.